So today we're going to be talking about pituitary apoplexy, and apoplexy means struck. So the patients don't know they have a pituitary tumor usually, and usually it's a severe headache, often the worst headache of their life. And as you know, the chiasm sits right above the sella, which holds the pituitary gland. And so if you have a pre-existing tumor inside of your pituitary gland and then it hemorrhages or develops necrosis acutely, it'll rapidly expand. And if it rapidly expands upward, it'll cause a visual field defect. And usually the field defect is a bitemporal hemianopsia because it hits the chiasm, which is the crossing point between the two nasal fibers. But it can also produce field defects that are ipsilateral and a superior temporal field defect, which is called the junctional scotoma, or it could produce a monocular hemianopic field defect called the junctional scotoma of Triquare, or if it hits the optic tract, it can produce an incongruous homonymous hemianopsia. So the lesions in patients who have apoplexy can be unilateral or bilateral optic nerve, chiasm, or the tract. And so when we see a patient who has an acute onset of painful field defect, whether it's bitemporal, junctional scotoma of Triquare, junctional scotoma, or homonymous hemianopsia, that's pituitary apoplexy. Imaging is required to look for this tumor, and usually what we're going to see is a rim of hyperintense signal intensity surrounding a hypointense core. So it can either present to us as a necrosis, a necrotic pituitary adenoma, or a hemorrhagic apoplexy. Both the necrotic and the hemorrhagic form of apoplexy present in the same way clinically. If the lesion extends laterally from the sella, it goes into the cavernous sinus. So the same stem, for example, a 30-year-old female who is postpartum, has new onset pain, headache, and ophthalmoplegia, that also could be pituitary apoplexy, usually third nerve palsy. So when confronted with any of these chiasmal type field defects or acute ophthalmoplegias with severe pain, you should be thinking about pituitary apoplexy. We need to do an imaging study of the sella, looking for the hemorrhage or necrosis. That's usually CT followed by MRI. They should be admitted to the hospital because you kind of need your pituitary gland, and so we're going to check the hormones. The ones we're worried about, of course, are cortisol, but you need to check them all. And it usually requires an admission to the hospital and neurosurgical consultation.